Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. We are live on the April 1st, 2016 edition of Finally Friday, No Fooling. I do want to thank you for choosing to spend your time with us here on Finally Friday today. And today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. We are also proud to partner with Sharon Easterling's company, Recovery Analytics. Finally Friday is now also sponsored by, my slideshow going nuts here. Anyway, it's sponsored by MedLink's Cost Containment, makers of Healthcare Audit Tracker. You can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate denials. Our newest sponsor, my slides are out of order here. Okay. Our newest sponsor is Mass Coding Solutions, a leading healthcare consulting firm with over 25 years in the medical coding industry. They have core competencies in medical coding solutions and medical coding education. If you go visit their site, you can see that they have complete courses on getting a lot of different class certifications. So take a look at their site. We're also sponsored by, let's get over to it, we partner with the Council for Certification of Medical Auditors, CCMA. They're the creators of the widely used Certified Medical Audit Specialist, or CMAS certification. And we are very proud to say that we have been approved to offer CEUs for all of our shows for CMAS certification holders. So if you have a CMAS or you want to get one, go see their site. If you want to get the CEU, you can find that on the This Week on Finally Friday page every week and download your certificate. Somebody's saying in the handouts they can't download the handout for some strange reason. Can you resend the link or just send the handout as an attachment? Yeah, if you put your email, the easiest way is if you put your email into the chat box, I will get a copy sent to you. Or I will, in a few minutes, once I hand off the show to somebody, I can put the link for it into the chat box. Okay, so where was I? Oh, we already talked about them. We already talked about mass coding. I wanted to remind everybody I sent an email out earlier this week. This is a heavy-duty coding conference, okay? All the presentations are like 2 hours, so there is no fluff here. They're not rushing to get through things. It's hardcore education. You can take a look at it at ICD-10codingconnection.com. I don't support or recommend many conferences, folks. There's this one and the boot camp, which Day is a part of, which we'll talk about in a minute. They're about the only ones I recommend. So anyway, that's something I suggest you go look at. Okay, today we are very happy to have two special guests with us to talk about how you can deal with managed care audits and denials by payers and how that's like dealing with the flu or diabetes or some other disease that you can never completely get rid of. But you absolutely have to treat it because, like the flu, it can be deadly if it's left untreated. So our two guests are Day Egaskiza, who is the busiest woman in healthcare, and she is the president of AR Systems Incorporated, the healthcare navigator company. I always kid her about being very busy. She is very busy. But she always answers the phone when I call. So anyway, and then we have Dr. Maria Johar, who is the system physician advisor for ProMedica Health System in Ohio. And let's see, I don't know if Maria was able to join us yet. Maria, are you with us yet? I haven't seen her on the call yet. Okay, well, hopefully she will be able to get here in a minute. Let me go back to this slide. I also have my loyal and faithful co-hosts on hand, Sharon Easterling, who's an auditor, speaker, writer, and appeal writer, and president of Recovery Analytics. And then my other co-host, Bill Mom, who's a practicing physician assistant, a speaker, writer, and a certified medical auditor. He holds a CMAS certification, and he's managing director of his company, Health Revenue Integrity Services. And Bill is joining us today, actually from the UK, because he's over there doing some work on population health management. So anyway, he's going to be joining us probably from the UK for the next few weeks. Anyway, so great to have all of you with me. One last thing I want to say before we go there is I want to make clear that the opinions shared on this show are those of the panelists and not necessarily representative of their employers. My opinions, of course, are my own and no one else's, and especially not those of our sponsors. So before we get started, let me switch over to, okay, I see a number of you asked for the handout. I wonder what's wrong with my link. Okay, well, let me try and find that. And in the meantime, let me get over to the website. And because some of you joining us today, actually a lot of you joining us today, I think, because we have a good number of folks on the call today. Some of you are kind of new to the show. If you are new and you're not very familiar with the control panel, it's that thing with the green buttons. The green buttons at the top of your screen looks like this. You see it? If you go to any page on Appeal Academy and scroll down on the right side, you'll see this box, and if you click on that, it takes you to a page that has instructions on how to use the control panel. It tells you how to get other kinds of audio connections, either by phone or the internet. And of course, if you're hearing me, you already got that handled. There is a chat box. I highly recommend you open the chat box during the show because it is a very active chat box. We sometimes have a different conversation going on in there. We are a discussion. This is not a lecture. This is a discussion group. You can make comments, ask questions, answer questions, whatever you want during the show at any time. Oh, okay. There, Dr. Hirsch has. He's given it access to. Okay, I don't know what that link is, Dr. Hirsch, but he's got a link for the handouts in the chat box. So if you're looking for that, go look for that. Thank you, Dr. Hirsch. The other thing is there's a button there that you can zoom in on the screen, which you might want to do on a couple of the slides because they don't have the biggest text. So just remember that when you zoom in, you're going to have to zoom back out. Otherwise, it stays zoomed in that way. But that way you can zoom in if I'm not zoomed in far enough. The participants list, that second button from the right, you are the one at the top of the list in your box. And if you hold your mouse over that, it gives you a little pop-up to come up on the side that lets you put your name in. You don't have to put your name in. Some people do, some people don't. And somebody asking for the phone number again. I can tell you one of the phone numbers. I'm going to put that in. It's 213. Well, no, I said I was going to do that. Now I can't remember what it is.
I would give it to you, but I don't have it handy. Oh, wait.
Sharon,
I do. Yep. I have it. 213
Yep.
226 1066.
And then the code is...
The 247?
247, isn't it? 080611.
Right.
And you hit pound. Yep. Yep, there it is. Okay. Yeah, you can use that same code for any of these phone numbers that people are putting in for you there. So, great. Thanks for asking, whoever's doing that. So, anyway, that's okay. All of that, there's other buttons on that, but no, I'm not going to get you control of the room or things like that. So, okay. Enough of that. Let's get back to the show. And if I can get that to come up again, there we go. Okay, so this week we're talking about managed care. Last week we were talking about, 2 weeks ago we were talking about sepsis. We had a whole show about that. We got another show coming up about that, probably because I'm trying to get Dr. Eddie Hugh to be able to be on the show with us because he just wrote an article about that. We'll talk about that in a moment. I'm not going to do much news today, folks, because Day and Dr. Johar have a ton of stuff to talk about. And I see Dr. Johar is on the list now. Dr. Johar, are you with us audio-wise? I'm not sure if she's there yet. Okay, well, we'll see. All right, anyway, so like we said, what we're talking about this week is managed care audits and denials. You know, one thing what we're doing today is we're talking about things that are at ground level, okay? This is stuff you need to do or you can do today to deal with things, and it leads into, well, what do you do in the future? Because just like these incurable diseases, you can't just treat them today. They're not going away. It's like diabetes. You can work on it today, but you got something you got to do, in future weeks. So there are other things to talk about. We're going to do another show. Future show will be more about that long-term stuff, but today that's what we're doing. Okay, Dr. Johar, Sharon or Bill, can you chat with her and get her I think she forgot one of the codes to be the panelist. Anyway. Oh, there you are.
On.
Okay, good, great, got you. Okay, good. Well, we're finally all here. Okay, a couple of things in news. I said I can't mention much, but here's what we are going to mention about. This is an article that was just published in the Health Law section of the American Bar Association by Jessica Gustafson and Clinton Michael. Actually, I've forgotten how to pronounce his name. They are from the Health Law Partners, and they're one of our sponsors, and Jessica is going to be doing a show all about this, about the legal ins and outs of this final rule about reporting and returning overpayments to Medicare in 2 weeks. So mark your calendar for the 15th. She's going to do that. But here's the link to the original article if you want to look at that in the meantime. I mentioned Dr. Eddie Hugh. He just wrote an article that's published at the American College of Physician Advisors. Highly recommend you go see that site, whether you're a physician advisor or not. I think you can register for the site and get to see that. I don't think you have to be a member of the organization in order to see the blog, but you have to register on the site. Anyway, this is a very good explanation by Dr. Hugh, and as Dr. Salvatore commented this week on RAC Relief, Eddie's, by the time you read Eddie's article, you've gotten through the hard part of understanding what to do with these definitions and what it means. And we are going to have him on. I'm doing my best to get him on a show soon. Okay, if you are a CMAS holder, there's a link on our website where you can get your CEU certificate for watching the show this week. If you have some other kind of certification like AAPC or AHIMA, I don't know how much you can get out of those, but you might want to download it just to try and get your organization to accept that. Maybe you can get half credit. They used to do that. Okay. Somebody asking, do you need to be a member to open the entire article on sepsis? I think you just have to register for the site, but maybe Dr. Hirsch, you might know the answer to that. I think he's online. And is there an app for this? You meaning for Finally Friday? No, but we do have a version of the site that is made for a phone. If you get on the site via the phone, you can actually get an app for Join.me. There is an app for that, so you could actually watch a show and listen to the show on your phone if you wanted to. If somebody wants to know more about that, you can go to join.me, find out all about it. It's free. Okay, a couple of other things I wanted to show you just quickly, just before we get started. I didn't have a chance to make slides about these. It was too early or too late this morning when I started finding these. There was, remember that case where CMS was trying to say that if they had a doctor who says they disagree with the medical necessity of something, that basically gives them the basis for a False Claims Act claim. They were trying to claim that. So your doctor's opinion basically wouldn't mean anything. Theirs would be the only one that counts. And if they disagree with your doctor, then they get to file a False Claim Act suit against you. Well, the court said, no, that's not going to work. That's been around for, months, more than 6 months. They finally got, there's where that is. You can see I'm probably going to write some more about it here soon on my blog. And there's also this one that just came up, which is about the new payment rules on hip and knee replacements. That starts today. So there are several articles here. You can find it on Kaiser Health News, and it points to, which is probably the Wall Street Journal, but you have to be a subscriber to see that. But then there's other articles here that I don't think you have to be a subscriber to go see those. Those may be something you want to do. If you're on LinkedIn, there's a group I highly recommend. It's called Clay's Weekly Medicaid Roundup. You can go join that group. It's free, and all this stuff is free. And the reason I talk about this, look at this. 25% provider rate cut is on the table to address budget holes. So that's happening. That's Medicaid, okay? So that's going to matter in your state. But there are states that are looking to do that. Then there's this, New Mexico, looking to increase expansion costs. And then they're asking, people to pay 2% of their income or $99 in order to split the tab on the Medicaid costs. That's being offered by Governor Kasich of Ohio, who's also running for president. Might tell you something about what he thinks about all this stuff. Okay.
And Ernie,
right.
that's very Australian. I think Kasich is taking it from Australia because they do that as well. They take a portion of your income to do that, yeah.
Okay. Well, it kind of makes sense, I have to admit. But anyway, makes sense to me. Maybe I'm alone. Okay. So let's get back. Okay, back to the slides, and we can see that we're finally getting over to what we're going to talk about. And this is when I was doing the research for this and everything for the show, I just said, can't be fixed with Band-Aids. You'd be amazed the kind of Band-Aids you can find out there on the web. But the problem is Band-Aids don't really solve problems. All they do is kind of, maybe they stop the bleeding, right? Wonder Woman Band-Aids, Darth Vader Band-Aids. I don't understand this one. Bacon strip Band-Aids? I don't understand that. But anyway, the reason I was looking for all that was because this is not something you can cure with a Band-Aid, just like the other incurable diseases. So here's what I found of the top 10 incurable diseases in U.S. healthcare. You've got Ebola, polio, lupus, here's the flu. What is this? I forget what this one is. HIV, there's just the common cold, there's diabetes and cancer, and then, of course, there's managed health care. That's something that is not going to go away. Why is it important? Because they are refusing. They are refusing to talk to you in a lot of cases. They're refusing to deal anything, just like some of the other famous refusals we've seen in recent months, Senator McConnell refusing to interview the President Obama, who refused to not nominate somebody for the Supreme Court. This gal, I don't remember her name, refusing to issue marriage license. Putin refusing to let go of Ukraine. Donald Trump refusing to admit when he makes a mistake. Lots of refusals, And the trouble is there's lots of things going on, and you can't use Band-Aids, okay? This is a Band-Aid ad for the Titanic. Well, unfortunately, that's the kind of solutions that you are being offered far too often, okay? People are saying they can help you with it. You need to do something more than just put on a Band-Aid. Sure, you need to do something today, and that's what we're talking about today, and Day is going to talk about that, and Dr. Joe Harn. As a matter of fact, see, this is here's Day's site, and if you pay attention, she is the co-producer of the National RAC Summit's 4th Physician Advisor and UR Team Boot Camp, which is in San Antonio this summer in July. And we're going to talk about that more in the future. And as a matter of fact, if you want to start signing up for that, I have a discount code for you. Write this down. Just as a discount code to get you the best price possible at whatever time you register. Best price possible is going to be good if you use the code APPEAL, APPEAL, okay? So when you register, you put that in the box, and you'll get the best kind of pricing available. Okay, so enough about all that. Day, it's your turn. I'm going to shut up.
You're going to advance my slide. You're going to advance my slide.
Yes, I'm on slide 22 because I know you're on the phone and you can't see what we're on. So slide 22, all yours.
Okay. Well, thank you so much, Ernie, for allowing myself to join you, and I certainly appreciate Dr. Johar being the other half of this. One of the cool things, and I do mean cool because I don't think we're as prepared as we should be. I was just having a great conversation this morning with 2 different VHA hospitals as we were talking about their managed care Anguish. And as I work with hospitals, as I hear from hospitals, as we read about in Rack Relief, as everybody's sharing good information, it really comes back to the same thing. I don't think hospitals are prepared for the onslaught of the managed care, especially Part C Medicare, that's been happening, especially in the last year and 2 years. When you're starting to figure out and you talk to a utilization review, first point of contact, and you're talking to that RN and you're saying, okay, United Healthcare, you're in your 5th day of observation. And have they been trained how to ask the question, what are you looking for inpatient? And so some of the situations I'm going to share with you are coming from some great hospitals, but they are not unique. And the other part that I think is kind of cool, as you saw in our Utilization Physician Advisor Boot Camp in July, we have now dedicated a half day to the managed care Medicare Anguish because it is so diverse. It is confusing to the first point of contact folks, our utilization review teams. We've got back-end denial management teams sitting in the business office. We've got contracting sitting in administration. We are just about as dysfunctional and silos as we can possibly be, and now we're getting hit. So if we think about what happened with the RAC when we first got hit with the RAC audit, the hospitals were so ill-prepared for the massive onslaught of records. We didn't do corrective action because we didn't have any humans left. They were so busy chasing the denial, trying to get the records out. Well, unfortunately, we're getting the same onslaught with the managed care plans, and just as we weren't prepared for the RACs, we may have RAC coordinators now who are doing back-end work, but moving that to the front so we can start changing internal dialogue, internal communications with the payers, internal with ourselves, because every payer has their own set of criteria. When somebody says to you, this patient doesn't meet criteria, or the worst thing for me is when somebody says, well, this patient doesn't meet medical necessity. I mean, if you want to get my hackles up, just say that a few times. Because what in the world does that mean? You know, to United, that may mean Milliman. To the Blues, it may mean internal what they've already created. To Aetna, it could mean whatever they say it means, plus the 2 midnight, plus readmission. I mean, pick a rule. And the payers have been notorious for not sharing that, or sharing it in the contracts, which UR never sees, or pre-cert never sees, or denial management fighting these. And so some of the things you're going to hear us talk about is clarifying of terms as well. Because in the revenue cycle, we have denials and we have dispute. And I think in this world of these new payers that are kicking us with patient status, these are disputes. It's like we want an inpatient, we deserve an inpatient. The doctor wrote a beautiful reason for inpatient, a beautiful plan, and you're going to tell us off. So some of the hospitals, I was just in some great New York hospitals, and they had a great denial management system, tracking system, and everybody was denied. So let's be clear. There are full denials, which are some we'll talk about today, but most of our payer disputes are over status. We do get a nickel when we should have got a dime. We get something, but we're losing those precious inpatients. Every payer has their own standards for appeals, and of course, these guys on the phone with us, Ernie and his team, are much better at knowing, but some of the big challenges we have are if you're not contracted. What if you don't have a contract with United, and it's a Part C plan? The contract says you get, what, 1 or 2 levels of appeal? If you're not contracted, what? You should get all 5? Who knows that? You know, I hear from dear sweet hospitals. There's one in Illinois I hear from almost daily. She's just onslaughted, and it's the compliance officer. She runs a census of about 55 or 60, and she said, it doesn't make any sense for us to contract with all these plans, but they're just killing us. So she wants to know how to appeal to all those plans, and it's a tough world out there for, the big hospitals. You're probably contracted with everybody but the kitchen sink. Not the mid-sized to smaller ones, especially when they see 5 patients a year with United,
Yeah,
So
I've heard, Dave,
oh,
that they could have as many as 800 to 1,000 payers that they are looking at trying to contract with. That's just it's ridiculous.
Yeah, I was in an 800-bed hospital in New York, and they said we're not contracting with United. It's not worth it. It is not here. It's not in our market. We will not contract with them because they have so much anguish with these contracts. So now they're trying to figure out how to deal with a payer who's not contracted, who keeps acting like they have to abide by the contract rules, and who in your hospital knows that. The dear sweet person calling, the back end, the contract people, who knows, CFOs? So as we deal with these new payer audits, our internal silos, we need to sit in a room with the flip chart and start saying, what do we need to do different? Because on page 23, this is kind of one of those most powerful, we're visuals people, and I do some free webinars for Compliance 360, and we're getting ready to do one on managed care, by the way, on all these anguishes on April 20th. And one of the things I'll be asking again is, where are you seeing the increase in activity besides the RAC? And as you can see, the commercial payer denials disputes have seen massive growth in the last 2 years. I was amazed to see this. And that's when I put on my hat and when I got to dig in, just like a bunch of you on the phone, Dr. Hirsch, I know you do it. We all need to dig in and find out how can we share a plan that will help our hospitals deal with this, because this is not like the RAC audit. Every payer has their own rule, and we've got to get sophisticated enough so that first point of contact, that utilization review, that pre-cert, that pre-auth person who very likely is in a different office than the person doing the concurrent on the floor, who is a different person than trying to fight the denial at the back end. We have to get people in the same room, because this growth is our new challenge. The 2 midnight rule is a piece of cake compared to this. Every payer gets their own rules. So then on slide 424, what are some of the big things we need to deal with? First of all, we should be educating. One of the reasons I like the 2 midnight rule, I love teaching it, because then you say to somebody, think about if you're Blue Cross now, because one of the battles we have with the Blues, Humana and Aetna and United, is what's the difference between inpatient and ops? The care the patient's receiving is very similar. So how do you defend inpatient? Very similar, very similar. So if the contract says it is only medically necessary care, well, I would never turn to a physician and say, yeah, by the way, would you just order medically necessary care so Blue Cross will pay us? That's almost so insultive. I mean, you got to get past that nonsense. So with Medicare, the answer is quite easy. Well, my patient needs a presumed 2 midnights to resolve the condition. And here's the plan for why they need 2 midnights. United, you like my plan? We don't follow the 2 midnight rule. Well, you're Part C Medicare. Yeah, I know, but we don't follow it. We have our own rule, which is medically necessary care. Okay, now that could be a deadly open the floodgates for denial. So Medicare gave us a good definition of the difference between in and outs, the declaration of 2 midnights or that second midnight with a plan. So what's our challenge with the commercials in these Part C plans is, what's the difference between the two? And they use it all the time to take away our inpatient. It's a frequent, disputed reason for downcoding. So we've got to beef up our records. What's the admit plan? Why do I have a plan for inpatient? Now, these carriers may be using Interqual or Milliman. So then our plan should speak to, if United is using Milliman to justify inpatient, my doctor has a plan for why they're an inpatient that also supports Milliman. We have to get sophisticated to know what that payer wants. So our reason for admit is super strong, but it also speaks to what that payer wants in the plan for why an inpatient. I think we have to be so careful to not say it's inferred. If you just read the record, you could see how sick they are. Just get out your checkbook, CFOs, because what we're learning is that will never fly in these audits. They're just looking for reasons not to pay us. So let's not make it easy for them and give them a plan. So slide 25, I'm going to walk you through now. These are because I have a bunch of these webinars coming up, I have some great stories to share with you, just a few of them, but these are the kind of things we're seeing. This is not traditional Medicare. So Dr. Johar is going to talk to you a little bit about the traditional Medicare anguish as it relates to the QIOs. This is the managed care non-traditional. So here's an example. This is a couple hospital health system in Pennsylvania. On a regular basis, after the inpatient level of care is authorized, medical records are requested, prepayment. Then they turn around and say, we never got the record. Doesn't much matter if they signed the receipt and the hospital got it back. Doesn't matter. The payer's going, we never got it. Well, we have the receipt, yeah, but we never got it. So that's just ridiculous kind of game playing. But, again, tracking and trending and making sure we hold them accountable through your contracts. But as I just shared with a great Indiana hospital this morning, they get your attorneys ready. They had to get their attorneys involved to stop. This is just ridiculous. This is abusive. But you have to have good examples. Then on slide 26, oh, go ahead.
I was just going to say on that, the business about sending something out and it being on the other end. You have to keep, I learned this in manufacturing, okay, sending things between one plant and another or one building and another even in business. You have to track. You have to be able to prove I sent this out on such and such a date. Now, and then, you've got to get that return receipt or whatever. So you've got to have these things. You've got to have them in order to prove it. The shame is that you have to do that at all. But in their case, in the case of these payers, that's what they're going to do. This is the game they play. So just like Day is saying, you got to have your lawyers lined up for this.
And I would like to add, I'd like to add in here that, like Day and Ernie said, every time we send a record out, we have that fax number, we have that FedEx number. It is, we are able to tell them, we have sent you this is our confirmation. If they have not been able to find it on their end, then this is a HIPAA compliant or non-compliance issue, and we'd have to report it as a breach. And typically, once we threaten that, they are always able to find that record. Always.
I love that.
Yeah, I agree with Dr. Johar. This is what you have to say. It's a HIPAA violation. It's a PHI law. The other thing is, in your contract, start before the fire starts. Go ahead and have it written in that you will only communicate through their portal. And if they don't have a portal, they have to write exactly how you're to communicate with them. So that if it's lost, it's their issue. Now, one of the things we had with one of the payers is they have a portal, but they won't communicate your results through the portal because it's done by third-party agencies that don't have access to their portal. And our comment was, I'm so sorry for your loss of the portal, but you're going to have to do everything through the portal. And so when you get aggressive with them, but if you've got 5 or 6 members or per member per month stuff, you're not going to get away with that. If that's a major payer for you and you're a big provider, you're going to get away with that. So, but always push them for the portal because your electronic health system may interface pretty quickly with those portals, and you can download stuff, you can get transmission records, you can get everything. And once it hits their portals, they're much better about saying they received it than if it goes by paper or fax.
I would say that the portal is probably the best idea because you can probably send one account at a time, one record at a time. Whereas with sending stuff in a big package, they may even say, "Okay, we found it, but you know what? We don't have this one. You didn't put that one in the envelope. You don't have much of a leg to stand on except your word that you included in the package. They say it's not in the package. I don't know what that result is, but."
And the good part of the portals is you can open up the record you uploaded. Within 24 hours, you should be able to see the record you uploaded and show that it's there. You can see it yourself. So do try to use their portals to the best of your ability.
Somebody's asking. Go ahead, Day.
No, I was just going to say those are really good suggestions, both of them. The portal is such a pro IT function; it makes so much sense to use. I know when I reach out to and I'm just going to give the Illinois hospital at the census of 50, they're going to tell me, I know them. They're going to say things like, that may be more technology for the one record of the 2 patients we see a year for this payer. We're going to stick with paper. So as much as we have both choices, I think every avenue that will hold their feet to the fire and give us better access. But since we deal with, hospitals with a census of 2 that are getting record requests from these payers, a census of 50, a census of 500, everybody better have a strategy to protect themselves. And if portal is one, HIPAA violation, such a good idea. But everybody better have something, because this is not you notice they said multiple payers were doing this. It isn't a payer. Okay.
Somebody's asking in a question, what about requiring them to do on-site reviews? I think we've talked about this in the past. I think that's another thing that, Bill, I think we can talk about in the future. I think it's a bad idea, but it may be a decent idea. But you've got to have some real rules in place. You're going to invite them onto your site. You better have some real rules and expectations in place about what they can and cannot do, what they're paying for, what they don't have to pay for. That's not something I would invite without a lot of work.
Yeah,
and that's the third party. The third-party auditors will try to do that. Generally, the payer auditors or the payer primary auditors don't. They want to do the field audit. They can get through much more. If it's a high-dollar case that they're trying to whittle down for supplies or something, they'll send somebody on site. So when they're coming on site, remember they've invested some significant resources into that claim. So be aware that they're not visiting for their health, and never get too friendly with them.
Yeah. Okay. Yeah. All right. Let's keep me going, because I don't want to run. I want to have enough time for Dr. Johar.
Yep.
On slide 26, Medicare Advantage. These are Part C. A lot of people don't know the words. Part C, Medicare Advantage. They are the same thing. When people are referring, you'll hear me teach traditional Medicare. That's Part A and B. Medicare Advantage is Part C. I mean, just trying to learn words, because we call it different things. Tend to use criteria that fits their need. Here's her example again, multiple payers, because I asked her to include the payers. When a one-on-one doc review is being done, the payer will not acknowledge the criteria they used and states they're using what Medicare uses, which, again, we're pushing for these national contracts to clarify in writing what they are using to define an inpatient. I've done contracting for 30 years of my life. I never can remember the day that we sat down and said, United, will you give us your definition of an inpatient? Aetna, I need a definition of an inpatient, one that is auditable and that we can hold each of us feet to the fire. So this is brand new. These Pennsylvania hospitals said they asked for it in writing, and they said, we're national payers. We don't put that in writing. So interesting how you defend yourself, or how you know what they're using when they won't give it to you in writing. And I know at least one payer who wrote that. So slide 27 is interesting. This is the all-time best. The only reason this is funny because I'm a woman and I've had babies. The mom delivered twins. You won't believe this. This is Pennsylvania. The mom delivered twins, and the payer, in denying some of the later stays, said the entire mom's case, asked for it, reviewed it, said it should have been done as OBS. Any of you delivered twins in OBS? Case is in appeal.
Oh, gosh.
I know, some of that stuff is outrageous. It's outrageous, and you don't believe it.
I had fun making that little panel there, DNA.
Yeah, I know. Oh, my gosh. I've got more cases. Some of them are ridiculous. All right, now here's another Medicare Advantage. This is Part C. Will not allow one-on-one doc-to-doc appeals. I think we've heard these. We call them peer reviews. And now what they're telling us, this was a Blue Cross, but it's not just Blue Cross, based upon Medicare rules. The payer upheld the initial denial on the first appeal. They're calling about the case again, but under a second review. So there's an outside company, a third vendor, who is doing the review for the Humanas. So in this example, Humana has their own. They're called payer integrity audit groups within Humana. But we know that one-on-one peer reviews are allowed, and they're certainly trying to find ways not to allow doctor-to-doctor communications. Slide 29, here's one where the DRGs are taking a beating. Inpatient procedures such as cardiac catheterization, third-degree delivery laceration repair are being removed from the DRG calculation. So the payer is coming in and taking away some of the comorbidities, some of the complexities that move our DRG payment from no comorbidities to a single to multiple. So by taking out some of those comorbidities, there's complications, it's reducing the payment. They keep saying that these additional items didn't impact the care, or the cost of our care, so why should we get a higher DRG payment? These are huge issues. This is definitely in violation of the HIPAA standard transactions I shouldn't say definitely, it appears to be, because we are required, and we are all payers too, they're covered entities, are supposed to be following the correct coding initiatives. Here we have a payer, and this is not the only one, by the way. It's just this one I tell you, I hear about this payer in other parts of the country. Just taking them out. Didn't cost us anything. It wasn't really part of the care, so you don't get credit for it. Now, physicians, you know full well you had to evaluate those complications. You had to evaluate their other comorbidities or other. But this payer is saying, nah, we're not going to let you have a higher payment, because it really didn't really have to do that stuff. I'm sure the physicians enjoy hearing that. Slide 30. Here's another one. An inpatient case from the case manager felt that the patient met inpatient criteria, because remember that the managed care plans, Part C Medicare, do not follow traditional Medicare. They don't use condition code 44. They use nothing. But the payer said, oh, we don't agree. We're using Milliman. So we have one hospital who is paying for Interqual. By the way, this is United, too. United uses Milliman. The hospital in upstate New York was paying for Interqual. They said, we have to have two systems? So on the phone call from Pennsylvania, they were told if you change the admit to observation before discharge, you'll get paid the obs rate. If you fight with us, or you appeal, or you change it afterwards, you don't get paid anything, because you don't even get to bill the downgraded observation rate. So
I love the attitude. That's the attitude of Darth Vader.
Yeah, I love it. If you ask for Humana, has now got, I do have it. Humana has now issued their after discharge, because we are having them and Aetna have said, if you fight with us to the end and you change a patient status after discharge, you don't get to do anything, because Medicare traditional doesn't allow post-discharge patient status changes. Yes. So they're essentially blackmailing you incorrectly into accepting the observation rate while I'm in-house as a patient, because if you wait till after I'm discharged and then you agree to the downcoding, you don't get to bill anything, which they then throw out CMS rules. And who on the other end of the phone, the little UR person, the sweet, kind, wonderful nurse, does she know that that's horse poop and that isn't correct? Probably not. So again, where is all this body of knowledge? And we need to bring it forward. So slide 31, this is my last slide. I'll get off of here so Dr. Johar can take over. The readmissions are just killing us, absolutely killing us. We have Aetna, who has, again, this is the Illinois hospital, but I get them all over the country now, that there are readmissions, all readmissions within a 30-day period are denied. And they actually had the nerve to put in print, just like CMS is doing. And I know Rack Relief has had it. I had to put it out on my free info line. Some of the stuff is just blatant lies, but on the other hand, who's being told that? The back-end denial management team in the business office? Have they told the utilization review that's not true? I will share with you a first-hand story. I had a professional acquaintance contact me. She was over she's a physician manager for all the specialties in her 200-bed hospital. And she said, yeah, we were just told that all denials in the 30-day period are being denied by Medicare. And I said, oh, that's not true. And she goes, oh, yeah, it is. We were just told, and they sent out a memorandum to the docs telling them all readmissions are now denied because Medicare is doing it. And it's that kind of misinformation. And so I went, oh, honey, that's not true. And she goes, yeah, it is. It was a letter from a payer. Then we have the issue, as I shared with you, about the disputed statuses. They can't bill anything after discharge, and this was another hospital, and it was in New York. So there are a ton of these. Okay, slide 32. Go ahead.
Dave, before you go off of this slide on the readmission piece, we do get occasionally readmission denials, when they try to submit it from the UR perspective while the patient is still in-house. We have escalated those cases to the physician advisor, and we actually do P2P, the peer-to-peer conversations with those payers. How I address them is, it is your patient. We had highlighted and given you all the information on the episode or the first admission that you had. It was your patient that you needed to do more complex care management outside our walls. What did you do? How did you communicate with the patient? Did you provide them all the tools that were necessary? Because that's what Medicare is paying you for, and which you failed to do. So your failure does not mean that you're going to deny a readmission because of your failures. And typically they back down. And they will say, yes, we didn't do it. They were actually not even part of our case management. Well, too bad, so sad. You need to pay us now and make sure that you assign someone to manage the patient on the outside. We are doing everything we need to do from when the patient shows up in our facility, and we are required to take care of them. We cannot get dinged for a readmission when it was preventable by you, but unable for us to do anything when, inside our walls. So they have actually taken and approved those cases for us. We also are actually meeting on a monthly basis with the Aetnas of the world who want to deny everything for any reason to address some of these readmission pieces. And we have also entered into a contract with them to manage or co-manage these chronic patients on the outside with them because they were unable to do so.
That's what. Why don't I do her transition to her?
Yeah, okay. There's somebody asking how many times do you recommend a facility appeal the denial with these other providers since they don't play by the rules anyway? I guess it's a question for you, Dave.
How many do we appeal? Well, you're not going to want to hear this, but you have to keep squeaking, guys. Because if you stop, it's the same reason that now what is the RAC appeal and overturn rate? We report that we have, so we're only appealing 40% still of all the RAC denials, even though we probably should do more. People are just like, it's not worth the cost. It's not worth the anguish. We're not going to get anything back. If you don't appeal, then they think either they've won.
They think they can get away with it. Yeah.
Yeah. Ernie, let me transition to, I need to get off because we're running out of time and I need to stop talking. I'm going to go ahead and turn this over to Dr. Johar. On slide 32, I wanted to kind of let you know there's two wins here. I'm turning it over to Dr. Johar, who's from Ohio, does 14 hospitals as a physician advisor. That's way cool. But she is now part of our team in AR Systems as being she's going to be the 2-day on-site physician advisor trainer for physician advisors who may need face-to-face, shadowing, learning how to do peer-to-peer. What she just said, that was a pretty cool strategy for how to fight the 30-day readmissions. She is going to join us and be doing, as a brand new service, physician advisor training program. So if anybody wants information about that, that's my website. Get on there or send me an email. Now I'm going to stop talking.
Yep. Okay.
I'm done.
Okay, Dr. Johar.
Okay. So thank you so much, Day and Ernie and the whole entire team. Thank you for giving me this opportunity. Ernie, you can flip, the slides maybe.
Okay.
This particular group, Finally Friday, actually has amazing talent and skills, and most of the folks, I think, we have no life really. We are constantly responding to emails, doesn't matter what time of day, or, we do answer questions if people have any kind of concern. I think the collective team, whether it is Dr. Hirsch, whether it's Sharon, Bill, Dr. Meyerson, everyone is more than willing to share their talents and skills, and I think together as a team, we are able to find a lot of good strategies against the managed care or any other company that tries to attack us. So we do have a very severe case of managed care attacks on each of our hospitals. I do believe that if we can provide them complete and accurate documentation, what I mean by that is when I do peer-to-peers, most of the physicians on the other end have half the information. They're saying, well, we didn't know the patient had this procedure. We didn't know that the patient was on more than one antibiotic. It is not because UR people didn't send it to them. It's because they didn't take the time to read it. It's sometimes the same issue is also on the RAC side, the Medicare side. We do these amazing appeals, but they don't read it. And the level 1 is, still denied. It comes back in level 2. In a lot of cases, these are canned letters. So be very careful. Read those denials. Read those responses that you get back from them. Go ahead, Ernie.
No, I was just going to say that's a really important point. There's a lot. I've been hearing that for years actually. That a lot of times they didn't get the whole record. They didn't get all the appropriate documentation. So very important.
And the peer-to-peers, if the patient is in the hospital and they have given you an opportunity to do peer-to-peer. Now I'll call out Aetna. They will tell you that you have the ability or the right to do a peer-to-peer, but as soon as they finish getting off the phone with you, they send a denial in writing, and then they say, no, you have passed the time now. So you have to be very, very careful. Somebody gives you 14 days, you have to be very vigilant on your time. So I have actually instructed my UR nurses that as soon as they say that you have the ability to do a peer-to-peer, they schedule one for me. Because otherwise, as a physician, if you try to get those peer-to-peer scheduled, you notify them, and then they look for a time that is available for their medical director to get back with you. It could be 1 week later or 2 weeks later, but they will not entertain that peer-to-peer unless you have notified them in a timely fashion. So get your process together. Make sure that if you want to do the peer-to-peer, you do it in a timely fashion. You were going to say something, Ernie?
No, I was just going to say that it reminds me of in the RAC program, they've kind of corrected that because they make it so that if you request which is essentially the peer-to-peer, which is all of a sudden the term
discussion.
Discussion period, they're not allowed. They have to give you the discussion period, but that's not true with these other payers.
That's
only applies
correct.
to RAC.
I do want to hit on what Dr. Johar was saying earlier, and Dave brought it up. I think she was talking about readmissions, and Dr. Johar mentioned that they hold the contractor, the payer accountable by saying that you didn't do what you need to do from a population health perspective. And I think that is a huge argument because they are mandated to do that. They are supposed to follow up with the patient. They're supposed to provide education, and that's going to be a huge part of MACRA. So I think that is a very good loophole that, you're going that angle, Dr. Johar, because that does hold them accountable. From a CMS perspective, that is a part of their contract with CMS. So that's huge. I do like that argument.
Right. Every time I have used that to tell them that, when the patient is sick, they've come to us, we are required to take care of them. You could have done a different you could have managed them on an outside in your chronic care management. You could have done whatever you could have, but outside of our walls. Once they get in here, you cannot deny us because of what you failed to do. So it has worked so far.
Yeah, and that's primarily, quote, Medicare Advantage has that.
Yes.
That's why they call you sometimes wanting to come to your facilities and educate or do whatever, partner, because they are required to do that. So I love that argument. That excited me. Thank you for that.
Moving right along then, we do appeals for each pair and we hit them hard. We try to do all the peer-to-peers. We try to do the first level appeals. If we don't get anywhere, we go every level. In fact, some of them will tell you only have 2 levels of appeal. Not true. We can continue to go just like Medicare. If they're Medicare managed, we can go level 3, level 4, and we have taken them at least to level 3s, and we have won with Humana. So that was, we were pretty happy about that. We have also, in Anthem's case and in Aetna's case, taken them up with our QIO. In Ohio, we have Ohio KeyPro, and we have actually gone to them for cases, and that has certainly backed down Aetna and Anthem. So they don't really want us to go to the QIO. In other cases, when we have too many of those, we have options of going to our state insurance board. We have tried to go to, we had one Medicaid company that we actually took to the state board, and an hour before we were supposed to meet with the insurance board, they capitulated on all 25 cases that they had been hanging on to for the last 9 months and refused to pay. So we do have some leverage. It's how do we exercise it? Do we have the right data? Did we do all the right things? And do we have a good paper trail to show that we did all the right things so that we can go to the insurance board? And by doing that, we've actually developed a better relationship with those payers. Let's go to the next slide.
Okay. Yeah, these are the KeyPro slides.
Right. So actually, if you go to KeyPro and you go to these other, whoever your state QIO is, these folks are actually pretty willing and to discuss issues with you. I would encourage everyone to go to their Ohio KeyPro or whatever QIO program is and see what options you have, what phone numbers you have. They will even do some education for you in your organization if you want them to come on site. Apparently, they are paid to do some education. So they are happy to comply from time to time. You just need to set it up with them. And then again, all of this information we will be providing again at our the boot camp that Day organizes, and hopefully we can see a lot of you in San Antonio again.
Yep.
All right. And to follow up with that, I won't be at the boot camp this year, but I know that we are seeing more Medicare Advantage denials because there are more Medicare Advantage than there have ever been. And that's all due to the Affordable Care Act. So these things are increasing, and because of that, we're going to have to prepare ourselves more. So, if you can go to boot camp, I would suggest you go there and get prepared because we're going to see more of this. And, of course, with the experience with RAC, these payers see that they can deny and, they can kind of do what they wish. So that's not going to stop. It's going to continue to increase. Even though lots of plans are pulling out of the healthcare market, you can be outside of the healthcare market and still have a Part C plan. So that's one reason why you're seeing more.
Yeah, now we have in the slides, there's some information about getting to KeyPro, but you can find all of this on the website, and then of course it's all printed out in your slide deck that you get now. And here's contact information for Dr. Johar if you have some more questions on that. Had some people asking about, let's see, Dr. Hirsch is posting some HIPAA information article. He's got an article about it, about all that information, using that argument with the payers. He's got that on his site, which is ronaldhirsch.com.
Hey, Ron.
RONALDHIRSCH. Yep, go ahead.
No, I'm just going to say there was also a kind of Humana has had some differences with Medicare. CMS is December 29th is what it's dated. Medicare Part C and D Oversight and Enforcement Group. So you may want to go and read that. There is a section on D, but there's also a section on C where Humana is having issues. So with CMS. So that's kind of interesting if you want to learn about some of the problems CMS. So when we say you must report patterns of abuse to Medicare on the managed care plan, Humana is actually now being held accountable. Humana is also getting bought or merging with Aetna. The hospital in Indiana that I just spoke to today said that one of the reasons that Humana is in such active conversations with their hospital is because they have a class action lawsuit against them, and they want it put on hold so they can merge with Aetna, because they have to disclose all those pending cases before the merge or the buyout can occur. So Humana is absolutely right now, it appears, in a very I shouldn't say more friendly, but more flexible to have conversation with than you may have found them in the past. So December 29th, CMS is slapping Humana's hand. Humana's trying to get bought out by Aetna. Those things are causing Humana to possibly have a different conversation with providers. Just something to think about.
Wow. Okay.
And I wanted to point out that all this is amazing information, but it's still my experience when I go into hospitals. The CFO has their financial dashboards and their financial daily discussion, and they're on top of their finances. But when I talk to people about their audits or denials, well, we got this from Humana. Well, is that a one-off? Is that a two-off? What is that? Well, I don't know. Well, where's your data? I don't know. We can't get at it. Well, where's your scorecard of what it's supposed to be? I don't know. The managed care people didn't get it. So I still get this siloed internally that's causing you to lose externally. So the efforts that are put into other things have to be done. You have to diagram out all your processes. You have to have scorecards on all your payers, big and small. You have to stick them with the scorecards, and when they violate that scorecard, you need to record that and keep records so that when they say, well, I need evidence of this, as they always do, say, well, I'm going to give you the evidence, and so is the insurance commission. They're getting it at the same time. Of these 37 cases where you said the exact same thing that was not right, you have to show them credible evidence, or they're just going to say, well, that was a one-off thing. We're not going to worry about that, when it is not a one-off thing.
I'd like to add that, within our system, our 14 hospitals, we have actually tied the front end, the UR, the scheduling, the payer specialists, the folks that are actually notifying the payers, as well as our appeals and back-end team together, so that if we start to see trends at one hospital, one payer, we are very quick in educating the entire team of what to look for and what to change to prevent these kinds of denials. So we have connected the front end with the back end.
Huh.
And that's key to all this. The front end has to know what to change.
Absolutely. And, if you're contracting with some of these different payers, then you need to know if you have a risk-based contract in place. And I go back to this, you got to wear two hats. You got to wear the hat that gets money in, and you got to wear the hat that protects your money, but don't prevent yourself from getting money in. And that could be also a part of your contract. Look, we're sharing some of this risk with you. We might not want to do that next year. So knowing that is key in helping you be able to do this. And, and that's if you're in a shared savings plan, if you're an ACO, if you're that type of thing, then you need to know that.
That's it. We are going to have another show in the next few weeks. We have a line on a couple of different people who actually work for managed care contractors. And we're going to try to get them on the show to be able to talk with us about, well, how do you work with the managed care organization? How do you work with them? What do you say to them that gets them to do this kind of stuff? And it will be a big help for your contracting department and for you. Basically everybody on the phone who you're going to need to get involved. You're going to need to be involved. You're going to need to do this contract work, because that is the future. The future is not in this stuff that we're talking about today. How do you deal with this, denial you got now? That's not going to take care of tomorrow. So you've got to do more than that, and that's what we'll do in the near future.
Hey,
so
Ernie, when you're developing that program this day, I think one of the biggest things I would love to see, and I'm going to have to start working on it myself, is when you ask the hospital, do you have a contract with United? Do you have a contract with Aetna? Do you have a contract with First Coast? Do you have a contract? Pacific Source. The question is asked, the answer is no. Because That's the key. We all talk about it. Everybody's got contracts. I can tell you in my old hospital, I never had contracts with these payers because I never had enough volume to warrant the contract.
Yeah.
So
Some of us,
the CFOs are like, no. I'm sorry, Sharon, if you're talking.
Yeah, I don't think sometimes they really know.
Yeah.
You know, if you're a big system, does he really know? But if you're
Well,
smaller,
I don't worry about the big systems. I worry about the 50-bed hospital, the 200-bed hospital. The one that I just talked to in Indiana is a standalone 200-bed hospital, and they have over $1 million tied up with Humana right now. I said, how about the other payers? We have literally no presence from those other payers in our community. That the employer base for commercials, and then, you know, what kind of marketing? Are they out getting the seniors to sign up to be a Part C plan? Many of there's an assumption that every hospital contracts with all these, that is not true. I had to, now I ask the question just like you heard of it earlier. You don't just ask, are you tracking and trending? We got to ask, tracking and trending, evidence-based by contracts. And then how about the payers you don't have contracts with? Does the hospital know how to deal with United when they don't have a contract with it? And it's commercial, and then it's Medicare Part C, because United has both. Aetna in Connecticut, that hospital has $300,000 easy tied up with disputes with commercial inpatient versus obs, and then at least that much, if not more, for Aetna's managed care Medicare, to which they have contracts with neither. So I think we as an organization and as trainers, Ernie, your groups, Dr. Hirsch, everybody, all of us out there trying to help, we had to figure out there's a way we better start teaching what to do when you don't have a contract. And I kind of talked to the CFO and said, you need to get a contract. He looked at me and he said, you know what? No, we have made a decision that the contract they're offering us is so punitive, we're going without one. So they made a conscious decision not to sign.
We in ProMedica had a contract with Humana and decided that it was not good enough for us to sign up with them again. So we walked off with Humana.
Yeah. I
Bill,
totally
go ahead.
agree. We've got to be strong enough to walk away.
Hospital in my facility, a vicinity that I could go to, and I could be, you know, a Humana patient, and I can go with one that has a contract that I could go to the other 14 that don't. It's very easy to happen here.
And does my 70-year-old Medicare patient know who's who? Does the 70-year-old patient know which hospital is the one they're supposed to go to? Really? They won't know.
Yeah.
Right.
Bill,
and somebody just had a question about Humana, that Humana doesn't allow for additional clinical for inpatient admissions. Once they have denied it concurrently, they won't accept anymore, but then you can do a peer-to-peer and still get that information to them. So through a medical piece, you can do that.
Okay, Bill, you had something you wanted to say?
I think, most of us that are providers have taken ACLS. We all know how to ACLS. We all know what to do during ACLS. But the bottom line is, how many of us have ever done algorithms for our payers? And when the smaller hospitals I see that invest in these algorithms and start figuring out what they need to do when they're out of network, when they're not. I mean, one of the biggest issues is anesthesia and OB. They're never in the same group, never in the same network. You know, how are you going to present it? Some of this is preventable through algorithms and through knowledge, but because the silos are so prevalent, you end up with these types of outcomes that are certainly adverse. So it is important to know when they're out of network, when you don't have a contract, when you do have a contract, what is all the ins and outs, so that your financial counselors can speak adequately to the patients, because these patients don't know. They know they bought insurance, and they may have bought it through healthcare.gov, and it was lucky they even got it there. But the bottom line is they don't know any more than you do. If you're supposed to be the source of information, your financial counselors cannot be the $9 an hour people. They have to be adequately educated and trained on how to look for these things with the payers. This inpatient-only procedure always is a nightmare. Well, you know, they went in, got a pre-cert, a pre-auth on one thing, but the doc ended up doing an open or something different, but we didn't bother to call the payer back and tell them that something changed. I mean, some of this is preventable that you own. Some of it is not. So when you've got your shop clean, then you can go and start attacking the payers, because then you really arm with good stuff. And it's been my experience, when you're really articulate with cases and you show them a pattern of behavior, they do back down.
Well, then that sounds like a good answer.
Yeah. Some of the, you're so right that, nobody knows what these contracts are. Some of our folks have gone and bought this from the Obamacare, whatever. They do not have the capability of getting observation care covered. They can only be covered if they have an inpatient stay. So now the patients are saying, you have to make me inpatient because I will not get any coverage at all if I'm an observation patient.
Yeah.
And how does a patient who is 62, never had, how does, the thing we all pretend is that our patients really understand the words we're all using. One of the things that we're learning is that we can talk like this amongst ourselves, but we got to be able to say to my 70-year-old managed care mother or my 42-year-old employer who's the first time they've ever been to our hospital, how do they have any idea of what we're all just saying? You have a Part C plan. Do you know what that means? Well, that means you have to call it. What? I'm sick. I need to see a doctor. Or what do you mean I don't get observation? What John Q. Public person on the street knows the difference between obs and in?
Well, I think what they've done with MACRA now is they're putting, as more and more population health and ACOs come into play, they're hoping that the ACOs will engage with their patient population and teach them, maybe the ER, maybe the hospital is not the first choice for treatment. And, if they're hoping someone else will do the education and not the hospitals.
Yeah.
We'll get to watch that roll out.
Yeah.
Okay. Well, look, this was a terrific discussion. We are way over time, but it's just such good discussion, and we'll do it again. Okay. Later in May, I think we'll do another show about this. Gives us a little bit of time to line up some of these other speakers and get it in. And I definitely want I want this whole team back. So we'll
see. May 20th. It's May 20th. It's already booked.
Yeah. Okay. May 20th.
I'm coming back.
Okay, May 20th. Well, then that's the day. Everybody mark that down. Next week we'll be talking about looking at CDI and try to get it pulled into all of this, because it's pretty much been focused in years past on fee for service, and now we want it to be focused on pay for performance. So we're going to talk about that next week. Week after that is Jessica Gustafson will be here to help us with talking about the self-reporting final rule. And then elsewhere in May, as you can see, we're going to have a case study about Top Gun Audit School. And then Sharon and I don't know, Sharon, did we decide? Well, we're actually doing a webinar, a separate kind of a special edition of Finally Friday that we will record and offer as a free webinar about her building blocks of documentation, which has been very well received by people she's been doing that for. So watch for all that stuff, ladies and gentlemen. And listen, thanks. Go ahead.
Implementing an ambulatory CDI program, Ernie. I think that's what.
Oh, okay. That's good. That's next week, or that's another one.
That's the next week. Yeah.
Oh, next week. Okay. CDI with implementing it for ambulatory. Okay. Well, listen, so we will be back next week live, April 8th, Friday, 1 p.m. Eastern, just like always. And so just watch for my announcements about that. Thanks to everyone for participating today. Special thanks, of course, to Kay Agaskiza and to Dr. Maria Johar for sharing their knowledge and experience with everybody. Also, thanks for everybody in the chat box today. That was a great other conversation going in there, and a compliment to what we were talking about. And, of course, thanks to my co-hosts Sharon Easterling and Bill Mom for all their help, as always. Of course, we want to thank our sponsors. They're the ones who pay for all this to happen every week, the Health Law Partners, MedLink's Cost Containment, Recovery Analytics, the CCMA, and Mass Coding Solutions. So it's their contributions that make these broadcasts possible, even though my dog's barking in the background. I don't know if you hear them. Anyway, watch for my emails about next week. we will, and please share the links to our show with your colleagues and friends. There is a recording of this. It will be up in about an hour, so if you want other people to listen to this, come to the same page where you got the downloads for this. It's This Week on Finally Friday on the Appeal Academy website. You'll be able to see that in about an hour. If you have any trouble with that, just email me or call me. Either one. I'm easy to get a hold of. I'll get it fixed for you. Anyway, last thing I want to share.
Ernie.
Yeah, thank you, Day. Thank you, Dr. Johar. Last thing I want to do is remind you, you can't do this with Band-Aids even if you use duct tape, okay? And the last thing I want to say is remember to write in Cheyenne Santiago for president in 2016. She'll make healthcare make sense.
And you'll see her at the boot camp. She'll be in the boot camp.
Yes, she'll be at the boot camp, and basically, so will Dr. Johar and Day and I. So anyway, thanks, everyone. We'll see you next time when it's finally Friday. Have a great weekend, everyone. Bye-bye.
Bye.